I would like to extend a warm welcome to our co-chair for today's session, Mr. Milind Maiskar, an IS officer from the 1992 batch, Maharashtra. He has over 30 years of experience across various sectors in public service and currently serves as Additional Chief Secretary Health, Government of Maharashtra. I would like to now welcome our moderator for today's session, Dr. Nishant Jain, who has closely been associated as an advisor for the PMJ scheme and currently heads the healthcare portfolio of South Asia region at the Asian Development Bank. Our first panelist for today is Ms. Aradhana Patnaik, an IS officer from the 1998 batch Jharkhand cadre. She has more than 25 years of service and was instrumental in the implementation of RSBY in Jharkhand. She currently serves as Joint Secretary, Ministry of Health and Family Welfare. Our next panelist for today is Dr. Ratan Kelkar, an IS officer from the 2003 batch Kerala cadre. He has had a very dynamic portfolio in his 20 years of service and currently serves as Secretary, Electronics and Information Technologies, Government of Kerala, and also additional charge as Executive Director, SHA Kerala. Our next panelist for today is Dr. Ajay Tandon, who has an illustrious career as an economist and currently heads as the lead economist at World Bank. Finally, I'd like to give a warm welcome to our final panelist for today, Dr. Shankar Prinja, a renowned health economist and ex-joint director at NHA. He is currently Professor for Health Economics at PGIMR, Chandigarh. I would like to now hand over the session to Dr. Nishant Jain for the opening remarks.
Thanks everybody for coming, and thanks to all the panel members and chairpersons for this session. And even though we are starting a bit late, still I think a lot of people will join as we go along. And this is the curse of a first session every time when you have this kind of event. Either just after lunch is not good or just in the morning is not so good. But I think, on the other side, people who are here means they're actually interested in this topic, so which is very good. And this topic is very interesting because when we talk about universal health coverage, I think this is a topic which is gaining more and more importance across the world. And in India also, I think governments both at the national and the state level are giving it. And that's where I think we have a very good panel here, where we have people from different kind of experience. So we have both the chairs who come from the government service, but then they took different routes and they have got varied experiences. Then we have panelists who are from the government side, from the development banks, from the academia. So we can get a very diverse and rich experience in this panel, and I'm very happy to have all these people here. And I feel that it will enrich certainly your understanding of UHC, what is happening, what is UHC, how we are doing, where we are going or where we can go, what are the things which may or may not work. I think we will be able to discuss all these things in the session today. So I'll just invite Dr. Indu Bhushan, who is the chair of this session, and we'll put up his slides.
So thank you very much. Is it on? Yeah. So thank you, Nishant, and thank you very much, NHA, for inviting me. I, through my 10 minutes allotted to me, will just set the context for this session, and I'll just go through some basics in terms of what is universal health coverage, because we sometimes have different view about that concept, where we stand right now in India, and from my perspective, what are the challenges that we should be looking at if we have to achieve and sustain universal health coverage. So starting with what is universal health coverage. So this is the definition that is universally accepted. It's a WHO definition. And if you look at this definition very closely, we are talking about three things here. One, that it's a service, not only curative service, but it's a package of service which includes promotive, preventive, curative, rehabilitative, palliative, and all health services that the person needs. So it's a package of services that we need to ensure. Second, that it should be not any service but effective and quality service. And so second element is quality. And third element is that the services are not supposed to be free, but they should be affordable. And they should be affordable for everyone concerned. And while using those services, they should not be put to any financial hardship. So with that, the two major feature here, and I think yesterday someone had raised this issue also, that when we estimate or we try to measure progress towards UHC, we look at two elements. One is that how broadly services are being provided, what is the coverage of services, and in using those services, what is the financial hardship or what kind of affordability is there. So we are looking at two dimensions, what services are available and are they affordable. And recently, the progress on UHC is measured globally through global monitoring report. And one of our panelists, Ajay. So Ajay leads that work globally, and he last week launched that report, Global Monitoring Report 23, and which looks at what has happened. Should I come closer? So that shows that. Okay, we have not put that. So that shows that we are slightly off track globally in terms of achieving universal health coverage. Our progress from 2000 to 2015 was very good, but after 2015, and partly because of COVID, it has been slightly disappointing. And while in terms of providing service coverage, it's still very good, but when we look at affordability, we are seeming off track and we are going in the wrong direction. So coming to India, if we look at the data, we find that we have done quite well in terms of UHC service coverage with respect to our income, because obviously the countries which are more rich have a better coverage. But if you look at this scatter plot which I am sharing here, you would see that India is slightly above the regression line. That will show that for our level of income, we are providing better service coverage in general. And as you can see, of course, we have a long way to go, but we are far behind most of the G20 countries and all the BRICS countries, which are actually much better than us in terms of providing the services. And in the index, the countries who are higher are better in terms of providing services, right? But if you look at affordability, this is another graph which shows that how affordable these services are. And on y-axis, you would see the proportion of population which is using more than 10% of their household income on health. You would find, and in this case, higher you are worse off. So you should be coming as lower as possible. Number of families which are spending more than 10% of their income should be lower. And as you can see that we are above the regression line, which implies that in terms of affordability, we have not done well. Most of other countries like Brazil, Russia, South Africa, Indonesia are much lower and have done better. So obviously, what this implies is that while we have done well in terms of providing services, but in terms of affordability, we have to do much more. That still is a challenge. And of course, schemes like Pradhan Mantri Jan Arogya Yojana and other many initiatives that we have taken will go a long way in terms of making the services more affordable. Now, I want to leave, that was what has happened so far in terms of generally in India, in terms of UHC, and I'll just leave behind 4 issues for consideration, and I'm hoping that some of the panelists will throw some lights on how those issues can be addressed. So first issue is that we have a very high level of out-of-pocket expenditure on health. If you look at this graph, we are actually we are one of the few countries which are very high. More than 50% of our health expenditure comes from out-of-pocket, and of course, which is not either efficient or equitable, because it penalizes the poor more and pushes a lot of people into poverty. And more than that, when people have to pay out of pocket, they don't go and they forego services. They don't use medical care because they can't afford it, or they delay. So once you have option of paying out of pocket, you have three options. You can forego the services, use services but you borrow and then go become poor, or you use inefficient services. You may use only half the course, or you may go to some provider which is not the best. So all three options are not good, and in that sense, one issue is that how should we reduce these out-of-pocket expenditure? How should we cover more and more people through either health insurance or providing services free of cost? And that is one major issue for achieving UHC. Second issue is that I had shown this graph earlier, and there is a similar graph, that as compared to our income, we've done quite well in terms of, say, under 5 mortality, and this graph is similar for most of the health indicators. You would find that as compared to our income, on average, we've done quite well. But when you unpack this in terms of number of states, and just look at this very carefully, India is there with the red dot, and I will disaggregate this into all the states, and these blue states are all our states, and this graph comes from Ajay, and very kindly shared that with me. And here you would find that India lives in several countries. There are countries like Bihar and others who show health indicators which are close to what is happening in low-income countries, sub-Saharan Africa. At the same time, you have countries like Kerala, where health indicators are actually better than most of the upper middle income countries. So they can't be one indicator for the country. We have to see that universal health coverage has to be achieved by each state, and different states have very different levels of governance structure, healthcare needs, and capacity to support their states. Third issue is that we are going through an epidemiological transition. As the top graph shows, that in 1990, burden of disease was entire or largely 3/4 was communicable diseases. Now more than 50% is non-communicable diseases. So there's a huge change in our burden of disease and pattern of disease. And second graph on the left is about aging. As you can see, that number of proportion of people who are elderly is increasing very fast. So our service delivery and our financing mechanism have to cater to this changing health needs. And if you look at the graph on the right, which is our UHC coverage, and here you would see that the top line, which shows the coverage of NCD, we are actually declining in terms of providing coverage for non-communicable diseases. We are doing quite well, which is the red line, in terms of providing services for communicable diseases, but for non-communicable diseases, our performance has been declining. So at the time when the proportion of health burden through non-communicable diseases is increasing, our service delivery should also keep pace of the change in epidemiological transition, and that is not happening. And finally, fourth issue is about the quality. And quality of health services, both in public and private sector, and together with that accountability, needs to increase. And we find that there is a huge variability of quality across states, across level of care, across type of providers, and even the doctors, sometimes when they work in public sector versus private sector, the quality they provide is different. So one has to see how we can do that. There are reports to show that bad quality service actually is worse than not using services at all. And in terms of quality indicators, one survey found that even within South Asia, we rank quite low. So I think for achieving universal health coverage, we have to focus on improving the quality. With these four, I will stop, Mr. Moderator, and look forward to the discussion. Thank you.
Thanks for a very nicely done presentation to set the context. And these four questions are very important. How do we reduce out of pocket? How do we tackle the inequities across the state? Service delivery, ensuring, and quality of the care. I think these four topics are very important for any country. And of course, for India, we are talking, then we can see that these questions become very important. And another thing which comes out very clearly, that there is no one path or there is no one magic bullet or a solution which can be adopted. And as we see there, it depends so much on the context and all. And the graph which Dr. Bhushan showed, where states were juxtaposed in the graph, you can see very clearly where Kerala was. Can you very clearly where Tamil Nadu was, where Goa was, vis-a-vis some other states. So that's why it's not easy to have a one-size-fits-all kind of approach in a country like ours. But at the same time, how do we ensure that there is some kind of coherence between what is happening across places? So I think that becomes very important. And that's where I think role of states become very important in the whole UHC context. Not only because health is a state subject in the country, but also because people move so much across the country from one state to another, and we need to ensure that they get the health care what they need, irrespective of wherever they are when they are sick. So that's a good segue to invite my next chair for the session, because Milinji is there as ACS from Maharashtra, ACS Health. And as we know, Maharashtra is the state which has done tremendously well in a lot of parameters. And within health also, I think on many things Maharashtra is doing quite well. But there are many other things in which Maharashtra is trying to further improve itself. And since Public Health Department in Maharashtra is leading all these efforts, I'm very happy that he has been able to join. So, Milinji, over to you for your remarks. Thank you.
Thank you very much, Nishanji. I first of all thank NHA for inviting me here for a very important session in this context of public health. Achieving universal health is really the most important motto that any health department should be having. I also thank Dr. Indu Bhushan for setting the context perfectly well to begin this discussion. And first, I would wholeheartedly agree with him about the investments in the health sector. In the state, we always keep debating about this, that whatever figures we look, whatever data we look, the investments in health keep hovering around 3%, 4% of the GDP or capital expenditure. And we always, when during the discussions about budget and resource allocation, we say that this is such an important sector, but what we are getting is 1% or 2%, and that's the real important point that he has raised. We know our individual lives that whatever we invest in, we get. If we invest in health, we will get health. If we invest in work, we will get rewards in work, etc., etc. So that is one of the most important things about health. Since I had the opportunity to work in various sectors of the government, including infrastructure and housing, I know this dichotomy or the rift very well. Because if you consider a metro line in Mumbai or a large rail or road corridor, they simply talk about 50,000 crores, 60,000 crores, 1 lakh crores, irrigation dam is costing 80,000 crores. All such projects, without batting an eyelid, discussions will be of this tune. What we argue that if you give us that kind of money, we can revamp our entire system within 1 year. But somehow that doesn't happen. Maybe that doesn't have a glamour. Upgrading a PHC is not as glamorous as building a metro line. Maybe that is the reason. But for whatever, especially that happens to schools also. The school department also says the same. If you give us that kind of money, our entire schools will be 5-star. But that's facts are facts, and this has been happening over the years and across the states. So that seems to be a kind of universal syndrome. And that is one of the most important points, that all of us in this room should always be fighting for more investment. Because how to spend that money, how effectively spend that money is the question that comes afterwards when we get that kind of money. So that is one very important point. Second important point, I feel that it should always be debated, that I had the chance to work as medical education secretary. Maharashtra has two different secretaries. One is medical education, one is public health. So I had the opportunity to work as medical education secretary some years back. And since then, that time, I am observing a fact that we have a terrible shortage of doctors. 30%, 40%, and I think most of the states might be having the similar scenario. Because we somehow don't value human resources that much. We feel that salary is a bad word, wages is a bad word, as if government's, how much expenditure is going of the government on salary is 60%, oh very bad. We are not spending on productive expenditure. But as we know, I studied chemical engineering in IIT, so I always think, what is different in IIT as a brand name? Are the buildings better? No. Are the labs better? Perhaps no. Are the libraries better? Not at all. What is different? Different are teachers. Teachers are world class. Like as we remember from our school days or when we were children, the doctor used to be the fulcrum. He used to see the tongue, he used to see the nadi, he used to see the eyes and would prescribe, and prescribe very effectively. But that institution somehow we are not valuing much. We are putting that institution under the name of salaries. Salary pe paisa ja raha hai. Sarkari logon ke tankhe pe paisa ja raha hai. So that is the attitude I think we have to change. We are doing a lot of efforts in the government saying that don't compare apples and oranges. A doctor working in the remote areas, and again as Dr. Indubhushan said very correctly, we are not only countries within a country, but we are countries within a state. Not only that, we are countries within a district. Consider a district like Amravati in Maharashtra. 10 talukas are like perfect, but 2 talukas are so remote, so tribal, it's very difficult to reach there. So these are the countries within the districts, within the talukas. So a doctor, an expert doctor working in that field is a different ball game altogether. But this is somehow our system. We have to keep convincing them. As secretaries, we try to tell the government that don't compare the salary of a doctor, a specialist doctor working there with any other government staff on the seniority, deputy collector, collector, whatever. So this is one very important thing that we have to debate upon. Do we dilute the structure of medical education if required? Because now today in India, engineers are abundant. Engineers you can find anywhere, but doctors, no. Doctors, we have to really make an effort to find a good doctor. So this is one thing I think we should debate about when we are discussing universal health care. Because now we are having health and wellness centers. Again, the same issue is we have everything. We have buildings, we have medicines, we have equipments, but where is the doctor to use all that? This we are facing in a state like Maharashtra, which is supposedly a progressive state, which is a comparatively richer state. And another thing I want to point out, that there are many indicators where we are good. Tamil Nadu, Kerala, Maharashtra is good in some indicators. But we have to realize that this is not necessarily because of our health system. Rather, it is in spite of our health system. Because we had a long tradition of women's education, we had a long tradition of social reforms, and that has led to all these results. We should not be patting our backs that we are good because of our health system. May not be the case. So that is one issue that we have to debate, that apart from the health system, there are various other things that we require. Like Kerala is a classic example, tremendous awareness about life and the basic human qualities. That is also one of the very important factors in the universal health care. And another important factor that Dr. Indubhushan mentioned is the NCDs. Before COVID came, we were all convinced that now the communicable disease is gone, it's past, and COVID awakened us again, that's a good thing. But we were thinking that now NCDs is the real thing, and that government of India is doing very good work in NCDs and lot of good intervention like STEMI or diagnostics, so that these diabetes, hypertension, cancer, their heart problems are getting detected in early stage. And I think we have to proactively work on that. I think that's all to begin with. I think if we ponder about, and I'm looking forward to the discussion in this session. Thank you so much.
Thank you, Milinji. I think you raised some very interesting points, and I'm very happy that you used the word investment in health and not expenditure on health. That's a very small thing, but that shows the mindset. Because in health, whatever we spend is an investment. It leads to many more things, and that is something I think is very important. And the role of medical education and reform in medical education, which is required further. And as you very rightly said, a lot of reform took place for technical education, and that is why we have so many engineers now. But for medical education, still it's much more rigid than what it could be, and there are examples across the world where some of these reforms have taken place. And in fact, Rohit, that reminds me that next time we should also invite medical education secretaries from many states. We somehow miss it, because in many states they are different. In some states they are same, like MP, but Maharashtra they are different. So I think we should, because tertiary care is provided through medical teaching hospitals basically. So now we go to our panelists, and I think we have a very good set of panelists which will really bring out the issues from different perspective. So we have with us Aradhana Patnaik from Jharkhand cadre, who is Joint Secretary Ministry of Health, and I think in her current capacity also she is dealing with some very important issues like drugs and all, which have huge implications on out-of-pocket expenditure in a country like ours. But I think also because I know her for maybe 15 years when she was looking after RSBY in Jharkhand, and she was the one who actually made it happen in the scheme in a very difficult scenario that time. So I think she can draw from her experience from that time also to have some things. So, one first question I have, that you have seen how tricky it is to manage a health insurance scheme at a state level, especially in a state like Jharkhand where you don't have too many hospitals available in the private sector. Public sector hospital reform is also challenging. So, and now you have seen how PMJ is evolving. So what kind of learning or suggestion you have based on your past experience and what you can see now?
Respected dignitaries on the dais and off the dais, ladies and gentlemen, a very good morning to all of you. I have, as Dr. Nishant said, I have had a very long association with health insurance scheme from the time 15 years ago when we had the first health insurance scheme in the entire country. That was the Rashtriya Swasthya Bima Yojana. I was spearheading the mission there in state of Jharkhand, which is my cadre. So as you all must be aware, Jharkhand is one of the most difficult states to work in. There's a lot of political instability, a lot of other issues like dealing with left-wing extremism. At present, of course, the situation is much better, but down the line of 13, 15 years ago, it was very precarious. Reaching out to villages was quite difficult. And if I'm able to recollect, at that time, though Naxalism was at its peak, during our various meetings, we could showcase Jharkhand as one of the most difficult states where RSBY could happen in spite of these challenges. A lot of tribal population, forest area, geographical challenges. In spite of that, a lot of initiatives had been taken by the state government which made it happen. As I move towards today, over the last 10-15 years, the change has happened from RSBY to PMJ. A lot of changes have happened. This scheme has done wonderfully well, and I think if I compare, the robustness of this scheme is one which is really worth mentioning. But again, I would like to focus more on the challenges, because I've recently I've spent 25 years in the state of Jharkhand, recently joined Government of India as Joint Secretary this year itself in April. And just 2 days before I was again in Jharkhand, if you are aware, we have the Ayushman Bhava campaign of Ministry of Health and Family Welfare going on in the entire country starting from 17th September, and the Pakhwada is from 17th September to 2nd October. So as Prabhari of Bihar and Jharkhand, I had visited Jharkhand, and 2-3 learnings I had during my 2 days visit. some challenges and some very good practices also I could see myself. One, as you all are aware, if we are talking of reaching out of universal health coverage. So what do we mean by that? Sir has given a very good definition, but I'll just get down to the field ground reality. Reaching out to the last mile for me is universal health coverage. So if I'm able to reach out to the last mile, then I have actually covered everyone. Now the challenges there are, we have the most primitive tribal group, if you are aware of PVTGs, primitive and vulnerable tribal groups, who reside on hillocks which have myself traversed there, trekked 10 to 12 kilometers. You have to walk on foot, trek on foot to reach out to those villages. So you can imagine what health facilities we'll be having there. So if those we can capture. So during my visit to Jharkhand, I saw that in one of the districts for the Birhor tribes, a special campaign was organized for covering all of them under PMJ, which was really very good. The collector there could think of reaching out to the last mile. So one thing which I feel is, if we focus on these difficult areas where access is an issue, if we have PMJ cards for them also. Second was, I saw that there was lack of awareness. So they also had an awareness campaign through the tribal language, through their dialect. They had Nukkad Natak for them and had brought about awareness amongst all the Birhor tribes who were residing in those villages. So one thing I feel which is really challenging today for implementation, for reaching out to the last mile in PMJ, is to reach out to these difficult areas, and those we can do through special campaigns. That is one. The other, I attended under this Ayushman Bhava campaign, we had this Ayushman Aapke Dwar PMJ, one is the one component, but we also have health melas to be organized in health and wellness centers and CHC level, apart from various other programs of organ donation and blood donation camps. So there, while interacting I attended one of the Ayushman Bhava melas. So there was a counter of PMJ where cards were being issued to now we have the self-generated cards. But while interacting with the technical staff there, I asked, सुबह से कितने cards बन पाए? तो 100 से ज़्यादा लोग आए हैं, लेकिन अभी तक हम 10 कार्ड ही बना पाए. तो मैंने कहा क्यों, इतना समय क्यों लग रहा है? तो सर कि OTP जल्दी आता नहीं है. I remember I had informed Basant Gar कि OTP का problem resolve करो. It was because of the server issue, network issue. It was raining that day. I can understand these are the challenges at the field level. At times network is very poor. So they were not getting the OTP, and continuously they were working towards getting the OTP so that they could finally register the beneficiary and give him the card. So that was one. The second which they said was that while after filling up the entire thing, say 90% data has been filled, and then there's a submit button, and at times the submit button doesn't come. So हम क्या करें? तो I said कि अच्छा मैं फिर वापस उसको जाके I'll work it out. And so just giving this example, I'm not trying to say that there are lots of faults. It's very good system, but these are actually the field problems which our field people are facing. So if we can make it more user friendly, lesser of inputs to be put, and more simplified, all of the entire technical team, it's a very robust team working on it day in and day out. If we can think of some even simpler things which we can, so that at the field level where there are issues of network issues, where accessibility is a problem, if we can simplify the procedures for them, so that it can be done. Maybe then after coming back to the headquarters where there's a good access, one can upload everything, and also that is one thing which I felt I need to highlight. Rest, I think a lot of things are very good happening, but one again there in such interior areas, even sir was talking of Maharashtra, we feel Maharashtra, Kerala are the leaders. But there also, sir was saying that in interior areas, doctors are not available. There are challenges of good hospitals also. We have empanel hospitals, but I was seeing the list, there are some very good hospitals who are not on board. How can we convince them? And this, I remember, was the challenge from RSBY days. How do we convince the good, reputed hospitals to be on board? maybe one of the challenges which still persist is the timely payment to the hospitals. So that's why the good hospitals don't want to come on board. So how we can work towards working with these hospitals so that all these services, good services with the excellent services are provided to the poor, because the PMJ cards are for the poor people, for the poor downtrodden who don't have access to health services. While the excellent hospitals are being accessed by the rich, somehow the poor are not able to access them. So how we can integrate them with with PMJ scheme, with our health insurance scheme. And since I'm also looking after drugs in the Ministry of Drug Regulation, Food Regulation and Procurement, so there again are issues of timely procurement, and that of course will not be resolved through PMJ, but drug availability. Like again in that visit I was asking, they were saying कि TB drugs एकदम shortage हो रहा है. So I promised them कि in 15 days हम लोग will ensure that they reach. So if that is also integrated in the PMJ, you already have the beneficiaries, you have the empanel hospitals, you have the list of doctors there, the human resource, everything is there. If drugs, also availability of drugs in each of the centers, be it state, or every state has its own drug procurement system, and also at the national level for national programs procurement is happening. So availability of all drugs in all the hospitals, if it is there in one portal, one can immediately access and get it, so that would really help improve, I think, the system. And a robust grievance redressal mechanism, especially if the beneficiary has issues, or as I gave you the small examples of OTP not coming or the server not working. So those, if we can have some self-generated system wherein immediately one gives a query and immediately it gets resolved, that would really help improve the system. I think these are my... thank you.
Thanks a lot. I think, many times when we sit in Delhi and we think about policies and all, sometimes the perspective from the ground gets missing. And I think thanks for bringing that perspective very clearly, that whatever we design, it has to happen on the ground at the end of the day, and the cutting edge is basically there. And you mentioned this OTP thing. I remember once I was also in the field and OTP was not coming and we were talking. तो बोला कि सर ये one time password नहीं, out of patience हो रहा है मेरे लिए. So yes, OTP and these kind of field level issues are very important. And how at the end of the day, we have to see how we can make life simple for the beneficiary. Whatever we do is the means. The end is that person should get healthy through a timely treatment, quality treatment, whatever it is. So, and on that note, I think I'm very happy that Ratan is here with us. He is from Kerala. So we talked about Kerala in presentations during our talk also. And we talked about the good things which have happened in Kerala in terms of the indicators and a lot of things. But at the same time, Kerala has its own set of challenges. For example, if you see the data of PMJ and even during RSPY or even before in NSSO, the hospitalization rate in Kerala is the highest in the country, always. And that reflects also in PMJ. Now, I'm not saying it's bad, but I'm saying it has implications in terms of cost, in terms of access, a lot of these things. So, for you, my question would be that Kerala is doing so well otherwise, but there are hospitalization rate is very high, which is leading to higher cost. And since the scheme is completely tax funded, how do you think about strategies to control the cost in a better way, try to see that the sustainability is ensured? Thank you.
It's red, no? Yes. Thank you, Nishant. Well, to answer that question, I may have to dwell upon a little bit on why we have a high rate of hospitalization. This is, and also the indicators, as pointed out by Indu sir in his presentation, also shows that Kerala is doing extremely well in terms of the parameters of health. So the Kerala health scenario comes about to this level basis the interventions which has happened over a period of say 80, 100 years. The kind of investment the state has got into the social development in terms of health, education, literacy movements, political reforms, social development. I mean, these are the things which has contributed to making people aware about the health needs. There's a high health-seeking behavior amidst the people, and they access the public health facility as well. And there is a requirement of meeting that demand. And the supply from the government is also coming to an effect because of the focus the governments have over the years had on the social development. Now, yes, like you said, there is a limit to what money can do in terms of or how much money we have with us. So one of the things that I've been personally doing since the past 3 years has been advocating with NHA to have a mechanism of funding rationally the expenditure which the states have been incurring for meeting the PMJ demand. Now there is a magic number which Indu Bhushan sir has put in NHA 1052 premium, which has not moved an inch in the last 3 years. So we've been advocating heavily because there should be a mechanism when there's a burnout ratio of 8 to 10 states, which is 2,500 rupees plus. We are still hanging around 1052, a magic number, which is an elephant in a room which refuses to budge. So things being so, we now understand that yes, there is some problem of money. The money is not going to be infinite. Resources are finite. So we need to manage the way in which we can manage. So what are we doing in Kerala is trying to tell people not to fall sick. So we are telling them, please be healthy. And we have our Kerala Health logo, and the slogan itself points that your health is your responsibility. Please don't say that your health is my responsibility. First, take a step towards maintaining your own health. That is the first thing. Second, we have made it very consciously known to all the departments that health department is not the owner of maintaining health of a society. The society as a whole has its own responsibilities. Individual citizens have their responsibilities maintaining a health of a society. The department can do only that much what is possible. So to that extent, we have turned the narrative to pinpoint to a fact that the society is responsible for maintaining its health. And to that extent, the local bodies over the years have taken ownership of these public health facilities. They also take and also fund the education, the Anganwadis, the field level offices, the public health facility. For example, the PHCs are linked to a Grama Panchayat. The Taluk hospital CHCs are linked to the Taluk Panchayat. The district hospitals are linked to the district Panchayat. So there is an ownership of this institution at the local level, which contributes a lot to ensuring that the supply-demand gap is met at the local level, and also the funding to an extent is also handled efficiently. Now, that has contributed to bringing about trust in the people when they visit public health facilities in Kerala, because they know there is an assured quality of healthcare which they can get from visiting a public health facility. That's the reason why we have, out of 100%, 60% of the claims are still met by the public health facilities. So to that extent, a costing on the government, we are looking at reducing. So that is the first thing which we have tried to do. The second part which we are attempting to do is trying to promote our health amongst people through our health and wellness centers, which is another vertical of Ayushman Bharat. So the health and wellness center, the promotive, preventive aspects of health is one thing which we are very efficiently looking at, writing so that we will get less people getting admitted to the hospitals. The other day, World Bank, I think authors are, 3 of the authors at least I know are there in this room, on the ambulatory care sensitive cases. I mean, these are some of the things which we are very seriously looking at doing, because we are already there, as pointed out in the slide. We are already there on that side of the curve where we are tackling NCD and hypertension, diabetes, COPD. These are some of the things which Kerala is handling in a big way, and this ACSC's very efficient way of intervention probably will bring down the cost to the government in the scheme. So that is another thing which we are attempting to do. Third one is we are attempting to strengthen our public health facilities and reduce the dependency on private health facilities to the extent of only strategic purchasing, so that we do not spend more money on private hospitals, since government also funds to a large extent all the funding of the public health facilities. So we are trying to rationalize and utilize the public health facilities to the extent possible, so that our dependency on the private hospitals come down. That is the way in which we've been moving forward. And multiple concepts of continuum of care. How do you link up, the institutions of the field with the center of excellences for the forward and backward linkages? Those are some of the other things which we are trying to manage, so that the cost for the government comes down in a bigger way. Another attempt which the SHA Kerala is trying to do is to try and find CSR funds. So we are in the process of trying to get that funding, and looking at managing some of the gaps which exist in the system. And basically what I'm trying to tell here is we are looking at a multi-pronged approach, where we are trying to promote health and wellness of the people. We are trying to reduce the cost on the government exchequer for meeting the requirements of the health of the people. And we are looking at other sources of revenue as well, so that we can manage a scheme efficiently. So to that extent, the role of NHA is paramount, because when we're looking at a central sector scheme, all the states' revenues are dwindling because of multiple reasons, as we read in the newspapers. So the amount which the health department is going to get would be only that much. So rest we need to manage. I think probably the way in which we can do is manage the money given to us more efficiently, more productively, getting, or rather preventing people from illnesses. And I think the way to go forward would be the ambulatory care sensitive cases identification at an early level, so that people stop falling sick and become a burden on the state exchequer. I think these are some of the things which the state of Kerala is attempting to do. Over to you, Nishant.
Thank you. Thanks, Ratan. And I think this was very interesting for everybody to listen what Kerala is trying to do. And not in terms of getting more money, but also in terms of using that money in a better way to try to get the maximum results. And I think I really liked about your health is in your hand, So that is something I think should be the first thought. And वो बोलता ना यात्री अपने सामान की रक्षा स्वयं करे. So that reminded me. So that is very important. And I think I am seeing, even when RSBY started, Kerala was the first state which incentivized public hospital to actually do well. And that time I remember NHM gave loan to the public hospital, saying you set up these help desks, all these things, so that you can start getting the patients. And that's why I think a lot of claims in Kerala are going to public hospital, which is another source of revenue for them. So thanks for sharing your experience, Kerala, and I think I know that your Karnataka experience also would be helping you a lot in Kerala, because you did something similar there. So now I come to Ajay, and we are very happy that Ajay is there with us in this session, because as Dr. Bhushan said, they have just come out with this report also in universal health coverage, and he is looking India very closely, because fortunately now he's based in India for some time and from some time. So he is in the best position to say that what he looked from somewhere distance, and now when he's in India, how things are moving on in terms of, when India talk about covering everybody, we are maybe covering 60% population right now, but 40%, and there also the coverage is not same. There is a big difference, and there are large overlaps and things like that. So, but what could be your thought process regarding, if India wants to, not if India wants to, but as India is trying to move towards UHC, what kind of suggestion you will have as somebody who is there in expert in this field in terms of not only how do we cover more people, but how do we ensure sustainability part, because that is something which becomes very important. And to collect premium from informal population at a large scale has its own challenges. So keeping that view in mind, over to you, Ajay. Thank you.
Me? Okay. Thanks very much, Nishant, and also to all the panelists already who have spoken. So, with regard to your question in terms of what advice to give countries such as India in terms of making progress towards universal health coverage, I'll just reiterate some of the points actually that Indu has already made. So one point I want to make is universal health coverage is not universal hospitalization coverage. So again, I repeat, universal health coverage is not universal hospitalization coverage. Many countries where we dialogue on these issues, there's this perception that it's hospitalization that matters, but it's actually not. So in the conceptualization, the definition that Indu provided, it's really coverage across the continuum. So it's coverage for prevention, for promotion, for curative care, for palliative care. So UHC is the entire gamut of the care continuum. In fact, as you're pointing out, we at the World Bank, together with WHO, we are, UHC is actually a sustainable development goal. It's one of the UN's, it's part of the health sustainable, the health bucket, that's UHC 3. And every 2 years, we at the WHO and World Bank come together and take stock in terms of assessing, working with countries to assess progress that's been made. And we actually look at sets of indicators, and those indicators are what Indu was summarizing. They include things like tobacco smoking rates, the extent to which you have access to sanitation, to what extent, if you have diabetes, are you treated, the prevalence of hypertension. So these include things that are amenable to public health interventions for promotion as well as prevention, and also for primary health care. And of course, one thing to remember is UHC for the first time for the first time in a global context recognized that the way a health system is financed matters. So previously, people may be familiar with the Health for All Declaration, the Alma Ata Declaration, the MDGs, the Millennium Development Goals. They didn't really put financing for health up front. In fact, the MDGs had a target for, I think, external financing, but not for domestic financing. It's the first time there's a recognition that how you finance health systems matter. So it's not only that you get sick, you also don't want your wallet to get sick, right? So that's one way to think about UHC. And so we measure not only access to the whole continuum of care, and these are just tracer indicators that we take into account that include things like immunization and skilled birth attendance, in addition to what I mentioned, but also we measure to what extent are households having to pay out of pocket when accessing care. And so the more a country is dependent on out-of-pocket financing, the worse it'll do in terms of, out-of-pocket financing is a risk factor for impoverishment. It takes away from spending on food, on education and other necessities, and so it also deters people from seeking care, as Indu pointed out. But it's also not just the direct cost of care that matters. I think somebody else on the panel has also already pointed out, we also need to worry about the indirect costs of seeking care. So indirect costs meaning the opportunity costs. So for instance, you may get free medicines, but if you have to wait 4 hours to get access to those free medicines, and if you're a daily wage worker, there's an opportunity cost to seeking care. So it's not just the direct costs, it's also the indirect costs that matter from an economics perspective, and that also needs to be put into context when thinking through universal health coverage. So, and the other point is that to sort of not think about universal health coverage from the perspective of a particular scheme. As was already pointed out, what happens in primary health care or doesn't happen in primary health health care will have consequences for hospitalization. So in many cases, we are across countries helping countries assess to what extent, what proportion of the hospitalizations are occurring due to ambulatory care sensitive conditions. These are conditions for which if you had access to timely and good primary health care, you wouldn't be hospitalized to begin with. And they include conditions like diabetes and hypertension, which if you had access to good timely primary health care, you wouldn't need to be hospitalized, or at least you won't, even if you're not able to eliminate all hospitalizations, you may want to at least try to manage them and reduce those. And estimates from Vietnam, for instance, are showing us that and in Indonesia as well, almost a third of hospitalizations are occurring due to ambulatory care sensitive conditions for which weaknesses in primary health care are causing a burden on public financing for hospitalization. So hence to sort of not only look at one part of the continuum, but the entire continuum, because what happens in one part has an impact on the others. And also to look at risk factors. So yes, individuals do have, I would say individuals are partly responsible for their own care, but there's a lot of public health interventions that are important. You know, think of air pollution. Air pollution, I'm not individually responsible for that. So what happens from a public health point of view also matters. And for communicable diseases, you know, what happens to you and you will matter to me. So it's not just the individual. It is really, you do need a public health lens to look at. Of course, the individual is a partner in that, but it's not the only factor that determines your health outcomes. So the other point I would like to make is also related to this, is that I think one thing that we have seen in many countries is you also need to now converge across schemes. So, you know, you want to converge to some extent, as was already pointed out, what's happening in the health and wellness centers with what's happening with PMJ. You don't want to have different schemes for the poor versus for the formal sector. You want to try and make an effort to bring these together. It allows for greater risk pooling and also greater redistribution of resources. It also allows the health system to reduce equities, because you're making access to the same benefits package or similar benefits package accessible to all. And also to have better convergence across levels of care. You know, NCDs was mentioned many times. The disease burden in India is now dominated by NCDs. And NCDs, there's one way in which NCDs really differs from other communicable diseases, and that's the chronic nature of NCDs. So unlike other communicable diseases, I'm not a medical doctor, but you know, when you get hypertension or diabetes, you are going to have that condition now for 40, 50, 60 years. The same person is going to have to repeatedly access the health system at different levels of the health system. So that requires a very different and a much more integrated response from the health system in order to manage care. And then there it also matters as to how you behave, your adherence to medication, your adherence to diet and exercise, that'll matter. And so there needs to be this partnership. So the reduction of fragmentation and moving towards much more convergence across schemes is to be desirable for in the move towards universal health coverage. And I'd like to make one final point in that the way a health system is financed matters for universal health coverage, as I made the point. And Nishant, you said, you know, there are many different ways. But let's not forget, there is only one way from a financing point of view to get to universal health coverage. So let's not reinvent the wheel. No country has made progress towards universal health coverage without compulsory prepayment. Compulsory prepayment meaning some compulsory way to prepay. And for many countries, that compulsory prepayment may be tax financing, because you have the UK style system, the NHS system, Brazil, Sri Lanka, Malaysia, many countries in Europe, all the Scandinavian countries, Portugal, Spain, Italy, Greece, they have tax financed health systems. That's where your resources for health are coming from, a payment of general taxes. So there's no earmark tax for health. But these are compulsory prepayment health financing systems. You do have the other set of countries where there's an earmarked wage-based tax that is also compulsory. These are social health insurance schemes. Examples include Germany and France and Indonesia and Vietnam. But again, it's compulsory to prepay. So you want those who are healthy to also prepay. You don't want a system which is dominated by out-of-pocket spending. Out-of-pocket spending is like taxing the sick. The sicker you are in your population, the more money your health system will get. You don't need a PhD in economics to know that there's something wrong with that, right? So you don't want the system to be incentivized so that it'll get more money the sicker you are. You want the system to be financed by prepayment from healthy people. That prepayment could be tax financing, general taxation, where it's feasible, where you have levels of formality that allow it. You may also want to consider an earmarked wage-based system. There's a third, the reason I'm using the term compulsory prepayment and not public financing is that there's a third set of countries that finances their health system by making it compulsory to buy private insurance, right? So these are very few countries, including USA and Switzerland, and I think Netherlands is the third one. So, that's sort of also a form of, it's not the best way to do it, it's more expensive. But again, it's compulsory prepayment, similar to, I think, what you have for insurance for traffic and things like that, right, for motor vehicles. But really, compulsory prepayment and a mechanism by which you're subsidizing the prepayment for those who cannot prepay, that means the poor, is the way to go in making progress towards universal health coverage. Thanks.
Thank you, Ajay. And I think this was a very good summary in a very concise manner on different aspects of UHC and different financing mechanism. And then at the end of the day, India has to decide what suits best in our context. And that is something, and also at the state level, there are variations which are happening. We can see that there are states which are trying to collect premium from certain part of the population, like Himachal is sitting here, and I think they are trying to do that. There are states which are doing fully subsidized for everybody, like Chhattisgarh is doing or Meghalaya is doing. And then there are states which are doing some co-payment, like Karnataka is doing. So there are different models which are being tested in India also, and we have to see, and it may not necessary that one model which is working better in one state can be adopted in the same way in another state, even though it's the same country. So those things also can evolve. And that's where I think it's very important that we see what suits best our context, and even instead of just copying. And I like this thing to say always that even when you copy in Microsoft Word, it says match destination formatting. So that is something which is very important. So with that, I come to Shankar, because Shankar has a unique experience, because not only he works as an academician, but he also worked as a part of NHA team for some time. So he saw from both the sides. As an academic, you can just say, oh, this is not working, that is not working. Now you do what you want to make it work. But when he sat on the other side of the table, he had to make that work also. So I think that from your perspective, Shankar, I think two things would be very interesting to know from your side. One, that you have seen that these different models which are being tested across states in terms of covering the uncovered population. So what is your view on this, and how do you see could be the way forward? And second, something I think which is close to your topic is on quality also. How do we ensure, Dr. Bhushan mentioned in his 4 questions, number 4, the quality part. So how do we ensure, because many times what happened that in the rush to cover more people and in the rush of getting more money, the quality sometimes get ignored or comes as an afterthought rather than being part of the system from the beginning. So over to you, Shankar.
Thanks, Nishant. And coming in last is actually sometimes difficult, but then with this illustrious panel that has already spoken, I think there's hardly much things that are left, but just to perhaps repackage the whole thing that has already been said. I think that the first question that you raised about how do we see the expansion of the scheme, especially in terms of population coverage. I think that the expansion in population coverage comes as a very natural choice in the context of PMJY. given that we have a sufficiently generous height of the cube, so we have about 500,000 cover, we also have reasonably comprehensive service coverage in terms of, at least if we look at the IPD, yes, outpatient coverage would definitely remain another big ticket agenda. So as a result, in any journey towards the USC aspiration, I think the population coverage would be a very natural choice. And I'll say that I'll just second what where Ajay left, saying that it would eventually have to be a compulsory prepayment model that would have to be followed in some way or the other. Now, and I'll give you the Indian reasoning for that as well. So as you said, that coming in, taking in the learning from outside, but then trying to make it contextually relevant and giving the local logic. So one of the options could be that you actually let people give some contributions for the coverage that we entitle them to. The point here is that we need to also look at the distribution of wealth within the Indian population. And there's been a recent study that has been undertaken by the Department of Health Research looking at what is the willingness to pay among the Indian population. And the purpose of that study was actually to look at what should be labeled as cost effective or not. So the purpose was to determine a threshold to determine what's that for every one, let's say, life year gained, what should be considered as cost effective. And the way that they tried looking at that was that they looked at how much people are willing to pay for healthcare services, how much people are willing to stay healthy. And that is in the event of when they fall sick. The final finding aside, one of the interesting findings is that if you rank order individuals according to their wealth status, till you reach the 90th decile, the graph goes almost like this. It is at the 90th decile that it starts to shoot upwards. That means while we continue to say that we have defined vulnerability as per SECC criteria, which covers only about 40% Indian population, there's a large chunk of population beyond the 40% which are actually quite similar to the ones that are there as our entitled beneficiaries. So, and for them, perhaps the willingness to pay even during for an episode of illness may not be as high. And that is very much linked to their ability to pay, which resonates from when you look at another source of data, which is the NSSO, which shows their overall consumption expenditure, which again follows exactly the same trend, that by the time you are at the 90th decile, you are still at the same point. So you don't 90th percentile, you still are almost like a flat curve, and then you start to jump up. So which means that voluntary contributions are completely out if we are looking at a coverage for the missing middle. So then we have two alternatives that are left. One is the mandatory prepayment, which is wage-linked contributions, which takes us to more of a SHI kind of social insurance kind of a model, or we go for tax revenue based as we are currently doing as part of the PMJY. I think given the employment base that we have between the mix between the formal and the informal sector of employment, I think eventually it will have to be a mix of both these two. So we do also have certain organized workers, organized formal sector groups of employees who can continue to be, where the coverage can continue to be expanded. And then we have this completely informal sector for which we will continue to have to rely on tax revenue in order to finance their healthcare. So that is one part of it. The other point that you mentioned about the quality and perhaps maybe even the efficiency for that matter. I think there are two important points in this regard. One is that, and this is again something that has already been mentioned, Ratan sir did mention in his opening remarks also, saying that eventually we will have to have strengthen the strategic purchasing function of the payer, which happens to be the NHA or the SHA. And within this function of the strategic payment purchasing, we will have to consider all the three aspects of strategic purchasing, which includes what to buy, which would mean that you would have to choose from amongst the services that are cost effective, maybe things that are high value in terms of promoting health, but coming at a relatively lesser cost. We'll also have to consider from whom to buy. And there comes in this argument of strengthening the public sector by perhaps maybe giving them the kind of nudges so that they come forward, perform, which is quite a win-win situation in the overall aspirational journey for UHC. And the third would be that how do we pay them and at what price do we pay them? And we would have to consider more refinement of our provider payment systems, etc. But the issue of quality is also equally important, and where I think we will eventually need to consider moving from more of volume-based payments to more of value-based payments. So somehow creating through both implicit and explicit incentive structures, the overall environment whereby the providers are nudged towards better quality. And I think that there are enough design configurations that are available within the PMJY. Perhaps it needs a better implementation to that extent. And I think that with that, there could be definitely an improvement towards more quality-oriented healthcare services.
Thank you, Shankar. And I think you were very clear in your thoughts, and that is something which I always like, that, you know, in terms of trying to cover rest of the population, what kind of mechanisms can be used, and knowing that in India we don't have more than 20% formal workforce, we cannot rely only on contribution, which is automatic contribution from deduction of salary, which is done in a country like Germany much easily, but you cannot do to in scale here, but you can do, but certainly you should not ignore it also, at least from the population which you can, you should. But for rest of the population, tax funding, but how do you do the tax, whether it's an earmark tax, whether it's general tax, all these issues comes into discussion, and I think that's a discussion for another day. And on quality part also, I think one very important thing what Shankar mentioned is that that how to improve quality, you cannot in a country like India, and especially where governance is many times a challenge, on a mandatory kind of thing, you know, on a regulatory thing, because even if you make a lot of regulations and all, you cannot ensure quality as much as you can maybe through some kind of nudges and incentives and things like that, which have worked very well in many cases. So I think that is something which is very interesting, and this I think with the study, willingness to pay study which you shared about is a very important study, I think. And I remember maybe around 15, 16 years back, there was a study on willingness to pay in India. And that study was very interesting because it showed that people are willing to pay a lot of money to buy health insurance, even if they're very poor. So everybody was very surprised that how come this study is showing something which is very counterintuitive or what we knew from the field. So then when people went into the details of the study, so in a very crude way, if I say, people were going to the researchers were going and asking the question, you have two options. Either you pay for health insurance or you die. What will you choose? So most of the people say, oh, yeah, we are ready to pay. So how do you design the study also becomes very important. But this showing that up to 90 decile, you know, that is something I think is very startling fact, and that is, I think, people often ignore. That when we put a line in the sand and say this is poor, this is not poor, that's a very arbitrary thing, because people who are beyond it also, and you are poor for what? So health expenditure, good families can also become poor if there is a major episode which happens in the family, and that is why being vulnerable and poor for health is different maybe from being vulnerable and poor for something else, and that is something which you need to certainly keep in mind. So now I think initially I thought that we'll go 2 rounds for each of the panelists, but we got such rich inputs only in 1 round, and then keeping in view the time which we have. So maybe I'll come to both the chairs for their reflection on what has been said. So maybe this time I'll start with Milinji, with you. That what is your reflection on what we have discussed, and on that, thank you.
Thank you very much, Nishanji, for a wonderfully conducted session. And what we connect from the field, some points I found very, very relevant. One is about, by Aradhana ji, about the availability of medicines. That is a very major important factor. With so much of technology and so much of pharmaceutical industries, we are still many times struggling that our primary kind of institutions don't have medicines on the right time. This will be a good takeaway. Secondly, about these IT problems of OTP, this is a very important thing, because that halts the work to a large extent. But more important than that, it hits at your credibility. For example, if you are sitting with a set of colleagues who are from other departments, and then you tell them that you will generate Aadhaar card on your mobile and the OTP doesn't come, general impression is that bhai ye kaam nahi karta hai. So so that is a very great hit towards our whatever other work we are doing. But one such incident literally finishes it all. So that is one important thing. I like this message of Ratan that logo is don't fall sick. We will also try to give it to our people. Let us see how much they follow. And thank you very much again for this excellent session.
So thank you very much, and I think you picked
Again,
up some.
Thank you very much,
Bhushan.
Nishant. You really very skillfully conducted this session, and also all the panelists, wonderful insights. And it's very difficult to summarize what everyone has said, but I'll pick up just one message or one of the many key messages that they gave from each of the panelists. I think my co-chair Milind was very right in saying that we need more money for health. Of course, without more money, we can't have universal health coverage. There is a limit to which we can have efficiency. There is a limit to which we can get more health for money, but I think more money is needed. But also he mentioned this issue of within the states also there are large inequalities, and we should be looking at that, and there are approaches that we need to think of in terms of incentives, how to put people there in remote areas. I think that's one key issue. And Aradhana, of course, had many messages, but one thing which also Milind mentioned was that, when you look at out-of-pocket expenditure across the world, largest amount of out-of-pocket expenditure comes from drugs. And unless we focus on drugs and ensure that there is easy availability of drugs, and those who can't pay, they should be supported, we will not be able to get universal health coverage. She also raised the issue of participation from private sector and how to ensure that they also join hands with public sector in providing affordable services, quality services to all of them, everyone there. And Ratan was also very insightful, and he said that health department is not the only department responsible for UHC. UHC has to come from various other things, and unless we focus on prevention, probably we can't achieve universal health coverage. And Ajay was mentioning later that no country has achieved UHC without doing prepayment, but I would also say that no country has achieved UHC without strengthening primary health care. And unless we strengthen primary health care and ensure that prevention is part of it, we'll not be able to achieve primary health care. He also mentioned that there is a limit to which we can get money. Money is scarce, and so we have to get more efficiency in the system. We have to get more health out of the money that is available, and we have to make sure that we use all our approaches to make it efficient. Ajay, of course, was very insightful again, and so ensuring that we have this compulsory prepayment is important. But again, if you look at our country, large number of our people are covered through prepayment, but there's a huge fragmentation in terms of our different schemes. We were discussing earlier that we have building and other construction worker scheme, which covers a large number of people, which overlap with PMJ. There's an overlap of about 20%, and the money that money could be saved if you use the BOCW fund, which is lying unused in many states. Similarly, there is a large overlap between ESI and PMJ. And if we can deduplicate that, there will be a lot of savings, and I think we can get more resources for health. So his view about prepayment, but also defragmentation of different schemes and converging different schemes is very critical if we want to achieve UHC. And Dr. Prinja, I'm always very fan of his work in health economics. I think I believe that he is one of the best health economists we have in the country. And his view that, we have this I think, false impression that, only 40% people are vulnerable. If you look at the distribution, up to 90% people, they are one shock and they'll be poor. So we have to expand our target group. We have to cover more people. This 40% will not cut it. But more than that, I think we also have to look for now value-based financing rather than volume-based financing to ensure that we are providing quality services and we are providing incentive for quality services, which is based on outcomes rather than inputs in terms of financing. So I think with that, I'll stop, but it was a great panel, and I'll ask you to join me in thanking all the panelists for their input.
Thanks, Dr. Bhushan, and I think I echo his thoughts completely. We got amazing insights. And when you mentioned just now that we need to say how do we pay for care. So I think not only for inpatient but also for primary care. Yeah. The way we are paying right now is through line item budget, through a budget. But I remember when HWCs were being conceptualized, we were also talking about payment financing reform, so that maybe money can be paid as capitation or a blended capitation or something like that, where there is a incentive for people who are working at the primary care level also to get money and to be accountable more. So I think that we need to broad base our thinking about only looking at hospitalization, go beyond it, and I think that is something very important. So with that, I would like to thank all the panelists, chair, co-chair, and everybody, and a very patient audience. And we really had hoped that we will have few questions from the audience. I'm very sorry, I apologize that we could not have, but you have the access to panelists after the session. Yes, please, we will make an exception, please. We can listen.
No, madam, I just appreciate your that comment on this at the health and wellness center. I mean, that are in the peripheries. I am actually from EMS Patna. I am the director of EMS Patna. So, as Sir Dr. Indu Hussain presented that slide, Bihar is in the, in the lowest in the this thing. Even this is, I was asking yesterday also. Even many MLAs, MPs, they make a phone call to me, Dr. Sahab, उनका कुछ भी नहीं है, आयुष्मान कार्ड भी नहीं है, वो नहीं है, कुछ करवा दीजिए. I really appreciate what Dr. Ajay Tandon was telling. There has to be your compulsory pre-payment system. Madam, my question actually, how actually this in the health and wellness center that are located in the periphery, somehow they are not that much linked, connected to the tertiary centers like ours, the center of excellence. We have a lot actually, but then somehow the link is missing. I think that, government can take some step to facilitate, maybe need of political will and also the governance, and especially the state government, because center has given so much, but somehow the link is missing. So my request actually that, to strengthen that, the tertiary care centers, also, to be connected well with the health and wellness center, so that the implementation is more effective. Thank you, madam.
Yeah, that's a very pertinent question, and in fact, I also have been pondering over it, because during my field visits, I was seeing this disconnect between the health and wellness center. And basically, if you recollect, see, all the services, the cutting edge is the health and wellness center for the rural poor. But and also wherever health facilities are there. But basically, our all the tertiary, secondary, and tertiary care, they start from the CHCs to district hospitals and the medical colleges and AIIMS. At present, what I was just contemplating, we have the PMJ access till the CHCs. If I'm correct me if I'm wrong, we have the kiosks at the CHC level. So can we think of taking it down to the health and wellness center, because the ABDM, the entire the PMJ thing is so robust. If we are able to capture it at the health and wellness center, link the PMJ card beneficiary to the till the tertiary care. So that can be possible. Not much of investment, what I was thinking. We don't need kiosks, but we have 160,000 health and wellness centers in the country, entire country. It's a huge number. Can we train the CHOs at the health and wellness center on this entire digital platform? Give them small, like I remember SHGs, I was Principal Secretary Rural Development in my state. So we used to give the, tabs to the workers, to the SHG women, and who were the community workers, and they would capture the entire, the banking sakhis they had become, they would capture the entire banking thing from this. So can't we do that for them? So say we provide, we ask the states to just give, if possible, laptops or computers, but that would be more costly, but a tab also, basic tab, which has, or we can also think of a mobile app, through which, once the beneficiary who has the PMJ card comes, his barcode is scanned, and then immediately someone, the CHO there present, does the screening, gets to know that this is the disease, this is where he has to be referred to, and then that goes up to the CHC, hits the portal there, then from CHC referred to AIMS, as you said, AIMS Patna, agar Bihar ka hi ek hum koi example le to. From there we take till, if it is linked, it can be done. Same down the line, आपका इलाज हो गया एम्स पटना में, उसके बाद फॉलो अप बहुत इंपॉर्टेंट है, कंटिन्यूम ऑफ केयर जो हम कहते हैं, to for that follow up, if again the person can be tracked till the final, or whatever doses he or she has to take, if that can also be brought in this digital portal, it will be like, I think we'll achieve what we want, universal health coverage, where there's prevention also, treatment also, care, everything is covered. So just an idea. Yeah, thank you.
Thank you. I think we got one question, but we took it as an exception, and also to show that yes, we had questions from audience. But I'm sorry, we'll have to stop now. It's a representative sample. So 15%, good enough sample. So I'll stop here. Thank you very much. Thanks to everybody. Thanks to a wonderful audience. And thanks for joining. And please join me in thanking the panelists one more.
Thank you, everybody, and thank you to the distinguished panel for an insightful and interesting discussion. We will conclude this ceremony with a small memento distribution. I would like to request our moderator, Dr. Nishant Jain, to hand out the memento to our chairs for today's session, Dr. Indu Bhushan, sir. And to Mr. Milind Maiskar. I would also request the moderator to hand out the mementos to our panelists, starting with Ms. Aradhana Patnaik. Dr. Ratan Kelkar. Dr. Ajay Tandon. And to Dr. Shankar Prinja. I would also like to call upon stage Rohit sir to present the memento to our moderator, Dr. Nishant Jain. Thank you, everybody. Thank you, everybody. Two small announcements. At the back of your card, there's a QR code. Please scan it for any feedback on the sessions as well as Arogya Manthan. As well as on the ground floor, there is a Ayushman Bhava selfie point to please get yourself clicked over there. Thank you.
Yes, sir.